Hi, I'm Steve Freedland, a urologist at Cedars-Sinai Medical Center, and it's my privilege and honor today to have my close colleague and good friend, Dr. Jun Gong, who's a newly minted associate professor of medicine at Cedars-Sinai Medical Center, a medical oncologist specializing in the treatment of GU, that's how I know him, but also GI tumors, which is what we're going to be talking about today. So, Jun, welcome.
Thank you, Dr. Freeland, and thank you for that warm introduction. I always love collaborating with you, and I can't thank you enough for your mentorship. Everything I've been trying to do is just to follow your footsteps.
No, you're outshining me, and that's the way it should be. That's the way it should be. So I wanted to talk to you. You and I talk a lot about prostate, but there's some really interesting data that just came out on colon cancer. It was for those who were at ASCO 2025 was the talk of the meeting, published in a journal. Something near and dear to my research heart is exercise. And so, why don't you tell us a little bit about the study that just came out? And it's the challenge study, and then I want to ultimately get into how we're implementing this. But let's hear a little. Can you tell us a little bit about the study and maybe the rationale for it?
Yes, of course, happy to. It was very attractive, gained a lot of buzz at ASCO, and especially since the New England Journal paper came out. And I really think it has, like you mentioned, a lot of potential broad applicability to not just colon cancer patients, but patients across other cancer types and disease types. And to briefly summarize, this was a phase 3 trial, the challenge trial. It was multi-center, primarily centers in Canada and Australia. It was enrolling patients who had completed curative surgery for stage 3 colon cancer. It did include some high risk stage 2 colon cancers, and these patients essentially completed adjuvant chemotherapy. And within 6 months of completing chemotherapy, they were randomized to two groups. One was what they called the control group, is the health education material group, and then the experimental group, which I'll call, is the 3-year structured exercise program. And both groups were in combination with standard surveillance after adjuvant chemotherapy. And the difference was the structured program really consisted of 3 years of a mix of mandatory supervised exercise sessions, as well as a combination of in-person or remote educational sessions with what they call a physical activity specialist. And so this was a long study. It took nearly 15 years to finish accrual. It accrued over 800 patients, and there were more than 400 patients in each group. And the primary endpoint was disease-free survival, which was a composite endpoint of either death or recurrence of cancer. And they essentially saw that the 3-year structured program had a superior DFS benefit compared to the control arm with a hazard ratio of 0.72, and it translated to an absolute DFS benefit at 5 years of nearly 5%. And so this was a positive study, and I think its significance is it becomes one of the first phase 3 trials that we have out there supporting the concept of exercise as a way to improve survival in survivors of colon cancer, when really before this, it was largely observational data. So it was good to have level 1 data for the first time.
Yeah, no, it was nice summary there. And what I found interesting, if you actually look at it, is they looked at both disease-free survival, which is death or recurrence, as you say, but they also looked at overall survival. And the benefits for overall survival were actually even better. And, you know, it's a reminder that people with cancer don't always succumb from the cancer. They have heart disease, they have other problems for which we know exercise has benefits.
Absolutely, absolutely.
So in terms of, I've seen some commentary, and I think, as you say, it's a 15-year trial. Having done these type of trials, they're not easy to do. It's much easier to randomize someone to a drug or not. Um, so this is a 3-year exercise intervention. How easy do you think that's going to be implementable in the real world?
I think that's one of the key questions there, Steve. It's really once the data read out, a lot of us were thinking, how do we apply this to the clinic the next day? And I think the feasibility is going to be one of the biggest concerns or drawbacks raised about this study is to have the resources to do a 3-year structured program. I don't think many clinics, at least in community clinics and even academic centers, have the personnel and the support to do such a study or such a regimented program. So I think that's where the applicability may be impacted. Um, but not to take away from that, I think one of the strengths was it really showed for the first time there is a target. I think their goal was to have patients translate a goal of an aerobic exercise of 150 minutes a week, approximately of brisk walking, which translated to about 3 to 4 miles per hour. And so it's nice to have that kind of target activity kind of laid out there when you look at current consensus guidelines. It hasn't made it yet, but right now they really haven't been specifically addressing some goals, target activity goals for survivorship across colon cancer, let alone a lot of other cancers.
Yeah, and I do think having that target, people like a number, and want to achieve that number, and the more is better kind of concept, which I think will, at least for me, I've often done, is I think challenging because at a certain point people want to do enough, and so having that target. But there's ways to get structured exercise, whether it's a physical trainer, through a gym, and the one thing that I think is always a challenge with this, and I know you've done a lot of work on this, is health disparities, and not everyone has access to a gym. Not everyone lives in a neighborhood where it's safe to go walking around. Particularly if you have a job, you can only walk at night. It may not be safe to walk around at night in your neighborhood. Can't afford a personal trainer. How do we implement this equitably for all?
I think again that's another key point that you just highlighted there is this kind of it kind of goes in line with that feasibility. How do we apply it? If you actually look at the study, this was in a randomized phase 3 study where you and I have published it before. When you participate in a clinical trial, some of the inequalities, the disparity gaps kind of get narrowed because everybody gets timely initiation and follow-up of such therapies. But even if you look at this trial, the adherence in the first year to the mandatory sessions is, let's say, I think it was above 80%. By the third year, it dropped to nearly 60% adherence to the mandatory sessions. So this was even in a, randomized controlled clinical trial setting. You and I can imagine in the real world, with a lot of the real world influences now, including racial disparities and access to care. This is going to be a huge challenge, no pun intended, to the exercise program. And so I think you just hit the nail on the head there.
Yeah, and I think the upside, and the way I look at it is glass half full, half empty. It's the half empty because it can be a challenge to do this. No pun intended. The upside is even with suboptimal adherence, as you pointed out, we still saw impressive results. So it doesn't necessarily, I think, require 100% adherence for every single session for 3 years. But I think the message is don't give up. You miss a session, you have a bad week, a bad month. Don't give up. You
That's
know.
so true. And I think that's a key message to help convey as part of this outreach and awareness that we spread to is the control group was really a health education materials group. So you can argue, what if it was compared to just a true sedentary lifestyle control group? Your benefits may even be better. So I really like that perspective you just provided, that as long as you just try your best and give it your all, you're gonna squeeze some juice out of this in terms of benefit and outcome improvement.
So what are you telling your patients? Your clinic this afternoon or tomorrow or your next clinic day, a patient walks in. they would have met eligibility for the trial? What are you telling them?
Well, I think there's two hats to this. My patient to provider interaction hat, I'm telling them, look, there's now level one evidence, phase three data. We have always suspected it, but now it's really been the granularity is a little bit out there. If you try your best to be active, and we can give them the target that the study was envisioning, we can say this is, 3 to 4 miles per hour versus walking 150 minutes for approximately a week. That should be a goal. On the other side is the programmatic clinician hat. How do we systematically apply this to all the patients? And this is where I've been reaching out to some of our supportive care, physical medicine rehabilitation groups here to see if we have either an internal referral group that we can refer these patients to, or even a third-party vendor, for example, a commercial vendor that can help support these patients in a more of a structured way that's close to the intended trial. And then in speaking with them, there's been a lot of hypothesis generating talks. They said, why adjuvant? Why not do prehab instead of rehab? And I think it's opened up a whole field of that's great. Patients going before surgeries, whether it's radical prostatectomy or colectomy, they should start looking into prehab as a concept as well. So I'll leave it at that.
Yeah, and I think that's great. And I think the next my final question is kind of, and I think you touched on this a little bit, is to what degree do these data you think apply beyond stage three adjuvant colon cancer to other stages of colon cancer, but other cancers as well?
I think it has really good applicability. It's very hypothesis generating. If you actually look at one of the tables in the New England Journal paper, it lists the other incidences of other primary cancers, including breast cancer, for example. And that table is really informative. It actually showed that even with exercise program in here, there was technically lower incidence of other cancer types in there as well. So I do believe that the exercise concept uh, should be and it's potentially applicable across a whole spectrum of cancer types,
Yeah, the rate of new primaries was essentially cut in half.
right? That's I think so. I think there's a lot to positive to take out of this study, to apply
Breast,
to another. Yeah.
prostate. So yeah, very interesting. Um, June, it's always great to chat with you. Enjoyed this, learned a lot as I always do. So keep up the great work, and let's get, get our patients exercising.
That's right. It's always an honor learning and working with you. So we look forward to collaborating as well.
Absolutely.